There you go. Right, we've shared. So it is 1 p.m. on Thursday afternoon if you're in Sydney, Australia. It is 2 a.m. Thursday morning if you're here in the UK. And if you are in the US, it is evening time on Wednesday night. So if you're joining us wherever you are in the world, thank you very much for joining us. We have Dr. Martin Weltman with us today, who is in Sydney, Australia. Martin is an old friend of the foundation. I emphasize the friend, not the old. But Martin's been working with us for many years now. And it's always nice to see him on camera and answer your questions. So on that topic, I need to say that what we're going to do today is we're not going to give you any specific medical advice, but we're here to answer any questions that may be helpful and to give you general medical information. What we're going to do today does not take the place of your own consultation with your own clinician, but hopefully what it does is add to it and hopefully empowers that conversation that you're going to have with your doctor in your next clinical appointment. So on that, and with that said, Dr. Martin Weltman, good afternoon to you. How are you? Happy New Year.
I am good. It's good to be in the new year, back in the thick of work. And
Absolutely.
It's all good. And we're excited because we're going to get new drugs for this disease, new medications this year. So we're very excited in our part of the world.
Fantastic. So let's start there then, if we may. So it's January, so that means the invitations to the summit will be coming out either later this week or early next. So it'll be good to see you back in the UK in April, if we can have your company for that. So over in Australia, where are we with second-line therapies? What are you expecting? Do you know what timelines are?
I'll put them down, the new drugs, as third-line therapy just because they've come in third line, not for any other reason. We haven't decided what's, second, third, fourth line. In saying that, the two drugs are going through our PBAC, so that's a pharmaceutical benefits type committee that makes an assessment. They make an application and go through all the consulting processes and provide all the data relevant to that committee, who never has a liver doctor on the committee, by the way. And they make an assessment as to approve that drug. So both drugs have had your equivalent of the EMA approval. So that's the Therapeutics Goods Authority. The drugs have been approved in Australia, both the new drugs, and elafibranor and saldepivir, and they will be they need funding, and the mechanisms of funding to get on our pharmaceutical benefits service will be first to be approved by the committee, and then there's a financial negotiation with this service, and then it has to have the Minister of Health has to actually approve that at the end once the bureaucrats recommend that. So my guess it's in process, and they both going through the process at the same time. I would assume they're going to assess the drugs at the same time, and they will make a decision somewhere in the middle of the year. My bets are, and I don't think we'll have the drugs fine. If we're fortunate, the second half of this year, if we're fortunate.
All right. Okay. Perfect. All right.
And that'll be good. That's encouraging.
Yep, absolutely. So we've had a question from the US in what kind of new drugs. So hopefully that answers that question. But just to give you a little additional information. So we have two drugs that are very, very similar. Not exactly the same, but they're both very, very similar. And they are said to be PPAR agonists. This puts them in the fibrate family.
Yes.
So you've got elafibranor and you've got seladelpar. In the US, both have been approved by regulators, although that approval is conditional. Whereas here in the UK, elafibranor has a full unconditional license. So there is no nonsense around confirmatory placebo trials or any of that going on here in the UK. I'm just saying. Just saying for a friend, if anyone's out there. But I think that's absolutely.
And do you guys have Seladelpa yet in the UK? Approved, or is it going through a process?
That's in the process of being going through the process. So we'll find out quite soon if that's going to happen. But again, we would anticipate that would go through. So
yeah.
Fingers crossed. Right, Terry says, I can't hear you talking, but it's showing captions. Okay, we'll just double check that that's all working. If anyone else is on live on Facebook, let us know if you can hear us or not. That would be much appreciated. Okay, so if you have any questions for us today, please do let me know. Martin, I'm going to start with a common question that comes up on a fairly regular basis. So can you talk to me about PBC and cholesterol, please?
So patients with PBC may have a high cholesterol because they have the usual risk factors, genetics, age. Often our patients are middle age or even a little bit older, and those patients often have hyperlipidemia and high cholesterol levels at that stage of their lives. So there may be just the familial genetics and being overweight and diabetes and bad eating habits and some genetics that predispose to hyperlipidemia or elevated cholesterol, much like anyone else in the community. But in its own right, PBC does contribute or predispose people to hyperlipidemia, and in particular, high cholesterol levels. Cholesterol is all the cholesterol we digest and manufacture is processed in the liver. So whatever we digest, all the fats we digest, the lipids are processed in the liver, and then they're distributed to where necessary. And if we have too much, it's distributed to places we don't want cholesterol deposits. So it's normal to make cholesterol, and we need some cholesterol. So that process is damaged. That regulatory process gets damaged and impacted by the disease in some patients. So patients with PBC have an intrinsic predisposition to hypercholesterolemia, elevated cholesterol levels. So it is something we do monitor in our patients with PBC. We do monitor their lipid levels, and that may vary depending on your age and other risk factors. The frequency of that may vary, but it should be something that is monitored.
Okay, perfect. That's helpful. Thank you very much. Okay, we've got a question here in the room in Click Meeting, but I'm going to break this question down into a number of general questions. So I'm going to ask you about Australia. Presumably, you guys would follow the APASO guideline?
I don't know if we follow any specific guidelines, and I think it depends on. I would imagine most of us follow the European guidelines.
Okay, all right. Interesting.
To be honest, some would follow the American guidelines, the AASLD guidelines, and they're not dissimilar usually, the American and the European guidelines. And generally, that's what's followed, not just for PBC, but I'm giving a context for other liver diseases. If they're good guidelines, people tend to follow those guidelines.
Okay, perfect. That's helpful. Okay, so could you tell me, please, just in really simple terms, what would it take to have a diagnosis of PBC?
So we would have two cohorts of patients, those sent to us with abnormal liver tests, particularly a high ALP, and that's been looked at and scrutinized and investigated to some degree, and they may actually find a positive anti-mitochondrial antibody and send them to a liver interested doctor or gastroenterologist like myself, and we have the diagnosis. Obviously, if the biochemical profile fits with the anti-mitochondrial antibody level, Some patient, well, we'll usually get some sort of elastography or fibroscan measurement on the liver to establish liver stiffness. That helps us stage the disease. And if we're not happy with the diagnosis, or we think there may be more to it, or we're more worried about that particular individual, they may need to have a liver biopsy. In the past, and I'm thinking back over a decade ago, every patient had a liver biopsy to have a diagnosis and have a definitive diagnosis, as well as staging of the disease. Since we've had elastography, that's become less necessary. And certainly, it's where you worry about a patient may have an overlap syndrome with another autoimmune liver disease like autoimmune hepatitis, or may have a lot of fatty liver, and we want to know the impact of each disease. So there may be specific circumstances where a liver biopsy is the specialist doctor would want a liver biopsy, but we don't do that many of them for PBC anymore, to be quite honest.
Okay, that's helpful. Perfect. Thank you very much.
Then we get other patients who come to a doctor like me who haven't had the proper workup, and we would go through that workup and complete that workup that the referring doctor has just found abnormal liver tests. Maybe they need to see a specialist, and we would do the same and find a positive anti-mitochondrial antibody. If that's negative and we have a high index of suspicion, and about 10% of patients, 5 to 10% of people with PBC have negative anti-mitochondrial antibody, we will do an extended autoimmune antibody screen looking at some of the newer autoantibodies, and we may get a diagnosis that way, and again, we'll then follow the same approach. If there's still a very high index of suspicion and everything's negative, those few individuals would need to have a liver biopsy to make a diagnosis.
All right, perfect. But nowadays, most people don't. So, okay, thank you. That's helpful. And so we have a diagnosis of PBC. We've got the biochemical markers that tell us that it's PBC. What would happen next? What would be the first line therapy that you would introduce?
So ideally, and it doesn't always happen next, Robert, as you know, we've had these discussions about good treatment and people who don't get such good treatment. Well, most patients are going to go into ursodeoxycholic acid, and there are a couple of brands in Australia now, and they're going to go into a dose per body weight, and they will be monitored. In our minds, if you come to a very liver specialized doctor who has an interest in PBC, we're looking at predictive factors. So we're trying to individualize treatment these days. So there's a list of factors that say this person's at greater risk of not responding or having more aggressive disease. And we want to highlight that in our records and have a clear understanding at the beginning. And then we would see that person at least the latest 6 months. And at that time point, really a good time point. And that may vary. You may be more worried about an individual and see them sooner. We'd expect to see a substantial response at that time to urso. And if they're having a decent response, you might stretch that out a bit because you want to try and get the liver tests and the ALP as close to normal as possible. So you might be a little bit more patient. If they have those predictive factors of a more aggressive disease, it should alert the doctor to saying, I think I need to be a little bit more aggressive with treatment. This is the time to really add a second-line agent if they fit the criteria. And the criteria in most Western countries are more or less the same to get second-line treatment. That does vary, and the funding does vary from country to country. And as you know, when we go to the summit, Robert, some countries are less well-resourced than others. So they may do it a little bit differently, and that's resource determined. But that's generally the way we would approach a patient. And I think most people in well-funded, well-resourced health systems would want to do that.
Perfect. All right. Thank you. So let's take the best ideal scenario, and that is that somebody has responded to urso. So the bloods have normalized.
Yeah.
So would that mean that they would then come off urso? They come off the treatment?
Definitely not.
Okay.
I'll say that quite strongly. This is a lifelong treatment. It's a lifelong disease. Stopping treatment means that that person's going to flare and relapse and may then may cause damage to themselves. And by that, I mean liver harm and further liver injury and scar tissue or fibrosis. And you always worry that you may not. We don't really know this because we don't stop lots of people and restart them historically, so we don't have good clinical trials or real world data on this, but you worry about recapturing the treatment response if you have to do it. Now, you may very well recapture the response and there may not be a gap, and we see this in patients who just say, I'm just not coming for my appointments, I'm not going to comply with treatment, and then they land up at their local family or doctor or general practitioner who does some blood tests and said, "Oh, you better go back and see that specialist again. This is flared. Are you not on your treatment?" "Oh, no, I gave it up. I didn't think it was necessary." So we do have some information, and that's a lot of that's anecdotal. All of us people who see a lot of this disease do have some experience with that, and we don't like that, to be honest. You shouldn't stop the medication, and particularly if you're fortunate enough to respond to urso, because urso is such a benign medication for so many people. It's so harmless, really, and non-toxic, and doesn't interact with a whole lot of medications. So it's really, in essence, no drug's perfect, but it's a really easy drug to use from a prescriber point of view, and a safe drug from a patient perspective.
Okay, perfect. Thank you. And in terms of ages of people with PBC, because we hear often, it's people between. Now, I hear everything from 35 to 55, 40 to 60, 45 to 65, all of those kind of things.
Yes, that's all real.
So yes. But in terms of, I guess I just want to just confirm that you can have adults of any age that have
any age. So most of the women we get to see, and it's mostly a female disease predominantly, are 50 plus, the bulk of them. But we see women of any age, and sometimes presenting very late in life, or it's been missed, and some quite young people. And we've written a paper that was published about 2 years ago, roughly, on PBC and pregnancy. So you see PBC and pregnancy, so that's much younger women, and it mimics other pregnancy disorders, so it gets missed actually, and no one really thinks of that as a first line diagnosis in that age. But we've had a few patients over the years, unfortunately, and they have very aggressive disease when they're younger, unfortunately.
Yeah. Okay, perfect. Thank you. Can you tell me, is there a link between arthritis and PBC?
There is a link. It's probably on an autoimmune basis. So again, we've seen women sometimes who are a lot older, and they may have wear and tear osteoarthritis like anyone of that age gets, and that's the most common form of arthritis. That's got nothing to do with PBC. That's wear and tear arthritis as we all get older. And so that your doctors do need to differentiate that, because that doesn't need treatment as of an autoimmune disease. But you get a small cohort of patients who, as part of their PBC, definitely get some sort of autoimmune type arthritis. So analogous, although not as aggressive as rheumatoid arthritis. It doesn't look like that. It doesn't distort the hands like that, but it's the same sort of inflammatory process you see in the joints. So there's definitely a linkage in some individuals. Probably a lot of it we don't know about because it's so low grade that people just live with it. But in some individuals, it can be quite significant. I've even had patients who've gone to see a rheumatologist for their joints. The rheumatologists have said, you better go and see a liver doctor, because that's the primary autoimmune illness,
Right. Okay, I'm with you. Perfect. So if somebody were to have arthritis, are there any treatments that they can or cannot take with their PBC?
Generally not. I mean, you'd have to discuss that with your medical team, but on prima facie, you wouldn't, except if you have rheumatoid arthritis. Commonly used drug that's an immunosuppressant is called methotrexate. And you'd have to check with your liver doctor, and you'd have to be very sure about this. Methotrexate can be liver toxic, so that would concern your rheumatologist. It would make them very wary, and it would concern the liver doctor. But if you have very mild liver disease, mild PBC, and you get a lot of arthritis of a rheumatoid nature, and they want to give you methotrexate, you'd probably say, well, let's start it and monitor your liver tests a little bit more carefully. But these days, there's a whole lot of newer agents that may be helpful anyway.
Okay.
And there's no specific reason why you can't have most of them,
All right, perfect. That's ideal. Okay, thank you very much. The question is, should we take multivitamins or something for the extreme fatigue?
So extreme fatigue is not well treated. It's very, very challenging. It's something medical experts, when we get together, discuss, present, are frustrated by. There's lots of experts write about this as part of articles on PBC, but we're not great at managing fatigue because there's no great medications that really help this fatigue, and the fatigue is probably multifactorial. And in some people, as this question.
Oh, Martin's frozen on my screen. So the question is that me or is that you? So I'm looking onto Facebook. Okay, still looking to. Oh, there we go.
Okay, so it just dropped out. So the vitamins aren't a good way of treating fatigue unless you have a specific vitamin deficiency. I don't think it's going to be that helpful.
Okay.
Yeah.
All right, perfect. There you go. Right, the other Martin has now departed, left the building. Okay, so that's helpful. Now, as a patient advocate and somebody who's worked in the foundation now for many, many, many years, I have an interesting take on the fatigue, and I think this is where self-care really, really comes to the fore.
I'm going to agree with this.
If you've asked this question, or even if you're dealing with fatigue, do please get in touch with us directly, because I'm sure that we can help you. And it's really interesting because sometimes, other doctors will say, well, there's no medications there, and so there's nothing that can be done for fatigue. And I would argue that in the strongest possible terms. So at the last patient conference that we hosted at the foundation, we actually had 2 physios that came from Birmingham, and they've been running a research piece on using meaningful activity. So it doesn't involve lycra, or not always. It can be full-on exercise, but it's just meaningful activity. And doing that in a really prescribed and directed way has helped fatigue enormously. There's also data that's come out from the Canadian PBC Society, where they've been using mindfulness and other self-care techniques, and they have improved the symptom burden as well. So I just want to say to you that there are things that can be done for the fatigue. It takes time. It takes consistent effort. But the data shows us that this absolutely does make a difference. So if you are affected by fatigue, please do get in touch with us directly. And what I'll do is, as Martin is answering the next question,
but I'll just reiterate that that's a very good idea, because there's a lot of other ways to manage fatigue, but I don't think vitamins are going to necessarily fix anyone's fatigue. But there are a lot.
Okay, Martin's gone again. Let's see if he comes back. He said the internet is a wonderful thing. So I'm in the UK, Martin's in Australia. We normally manage not to have any of the. So
Can you hear me
we'll
now?
just yep, I can hear you now again. Hello, sir.
And with the fatigue, I would encourage people to manage it. There's a lot of self-help that can be done, and in the future, we will, once we understand the biochemical pathways and the biochemical disturbances that contribute to this fatigue, we'll have medications that can deal with that, that'll target those metabolic pathways. But we really don't understand it very well. But the future will be the future. We always know that there'll be better things in the future.
Indeed. No, absolutely. No, I appreciate that. Okay, thank you. So again, we're waiting for more questions to come in. You mentioned earlier that you wrote or co-authored a piece on PBC and pregnancy.
Yes.
Is there anything you want to share with us in terms of the main points that came out from that paper?
Yes, so we did a meta-analysis of the small. Meta-analysis is the way of taking all the small publications that people have published, the little cohorts from big centers that might have a group of 12 patients over 20 years or 18 patients, and they've published that data, and we merge them all together, and then it gives you a greater data pool to analyze, and it's a much more powerful way of a more accurate way of looking at the statistics. So that's done quite frequently with in medicine today, looking at look at outcomes from all diseases, and so we looked at PBC and pregnancy, and what you do note is it's usually an aggressive presentation, so very, very high ALP levels. It's often missed as a diagnosis because of the age group, and because there's a disease called cholestasis in pregnancy that presents within a very much identical liver function test disturbance, and the patients don't have liver biopsies, so you can't be sure which disease it is. And cholestasis of pregnancy is very threatening to the fetus. So that we use the same treatment, fortunately, which is ursodeoxycholic acid, and it's a very good treatment for cholestasis of pregnancy. And when you use that treatment, the liver tests do improve, and there's a rush to deliver the baby as soon as it's safe to deliver the baby, because this disease is very toxic to the baby. And it's often the diagnosis of PBC is made post-pregnancy or postpartum, because the urso stopped. The minute, if you've got cholestasis of pregnancy, the minute the baby's out, the disease goes away. And so they stop the ursa, FOLC, or the ursodeoxycholic acid, and then this mum goes home and gets along the merry way, and a few weeks later, often, or months later, they're sent back to see someone. Said, why is the liver test so high? And the ones I've seen, that's when I usually get a call. Well, you're the liver guru. What do you think? And you tend not to think of PBC straight away, but this is what the paper shows.
Yeah. Okay, perfect. That's
and that people have aggressive disease, and we know they also have an aggressive. They don't respond as well because we stopped the ursodeoxycholic acid as one of the people asking a question asked earlier, and then the liver tests really go off and become very aggressive and difficult to manage. The patients we've seen, fortunately, we have these newer drugs, but in the past, some of them even had, it's not a insignificant transplant rate in this patient group. And they're young.
All right.
They're in their 30s, you know.
Yeah, gosh, okay. Thank you. Okay, we've had a question in and around gastritis. Are there any safe medications that you can take for gastritis that won't interfere with urso?
You could probably, the reality is, even though it says it interferes, you could probably have all these medications in real life. So real life's
Okay.
not always what's in the patient information sheet. I would just say you should take it at a different time of day. That's all. So if you're having your Mylantin PPI before you go to sleep, for example, you could have your urso spaced out through the day, you know, in the morning and early evening, or vice versa. You could have your PPI Mylanta in the morning and your other medications a bit later. But if you had them together, it's not going to make a huge impact. It's a theoretical interaction regarding absorption of the urso, but it's not. There's enough urso on board that it shouldn't be a big issue for most people.
Okay, perfect. Okay, so we're going back to pregnancy again. Are
I
there
like
any
this question.
precautions? So are
I've
there
never seen this question asked ever, so this is a first. And thank you
splendid.
for the question. There's always a first when I come on one, and I've been doing this for a while. So most women are not diagnosed with PBC prior to pregnancy, so that's a very unusual situation. And I'm imagining that you're young, or whoever you're asking the question about is quite young, and that's fascinating. My advice would be, and it's just based on experience, there's no data, you should really have your liver test well controlled. 20 years of age is really young. Okay, well, that's young. It's getting close to a record. Okay, you should really have your liver tests very well controlled and remain on your medications, and then it should be a normal pregnancy. If you go into pregnancy with your liver disease controlled, I would imagine there can't be, and assuming that you don't have cirrhosis and those issues, that's an issue in its own right. If you fall pregnant with well controlled liver tests and you don't have much fibrosis, that should be a normal pregnancy. It shouldn't flare. It shouldn't be an issue. And if any liver issues happen, it's pregnancy related, not PBC related. And it's the same for most diseases now. Like we look after other diseases. If the issue is, if you have a serious underlying medical illness, you should not fall pregnant until that disease is controlled. Generally, if you can control the underlying medical illness, the pregnancy shouldn't be different to the normal woman falling pregnant.
Okay,
Thank you
perfect.
for the question. That's a really thought-provoking question.
Good question. See, we've been doing this almost 4 years now. And it's great that, new questions are coming up all the time, which is absolutely
Yeah, it keeps
fantastic.
us on our toes too. So thank you.
Yeah, perfect. Okay, and just again here at the foundation, we've heard of many, many people who have PBC, particularly who have been diagnosed younger, who have gone on to have pregnancies, and gone on to have healthy and happy babies and all of those
Yeah,
kind of
it
things.
shouldn't be an issue, really. I would really encourage you to, just as long as everything's normal, the pregnancy should be excellent.
Okay, perfect. Thank you very much. So another question that comes up quite regularly, and this has been inspired by the idea of contraindications, really, with other medications. So, what can you tell me about pain and pain medication and PBC?
So if the liver's not too damaged, so not too fibrotic, you're not
Yeah.
cirrhotic or don't have very advanced liver disease, of any sort, not just PBC, any cause of liver disease, autoimmune hepatitis, alcohol-related, whatever, you should be able to have most painkillers really no different to anyone else. So
Yeah.
we're not encouraging people to remain for months and months on painkillers, but your doctor, if you have an issue with pain, your broken arm, or you have surgery and you need some painkillers, in the short term, there should be no problem at all, really. Now, it would be different if so someone's asked about pregabalin, and it should be. I can't see that it would be any different. I think pregabalin would be fine, actually. It's different if you're
Okay,
cirrhotic.
perfect.
Then you really have to ask your specialist how advanced your liver disease is, how safe it is. So if you're at risk of decompensation, you're going to build up. You may not metabolize, say, for example, opiate drugs as well, and the blood levels will build up and it can become toxic. So you would need lower doses or less frequent painkillers. The nuances there that your specialist would help you with, but most painkillers and pregabalin, I don't think. I've never been asked about pregabalin, but I would be happy for my patient to have that.
Okay, perfect. Thank you. Now, here's a new one for me. So here is the question. Could Repatha,
Sorry,
I'm
I didn't
guessing,
get
so
that.
it's Repatha,
Repatha, yeah?
Repatha, R-E.
Yes. I know Repatha,
Yep.
yeah.
Could
Yeah.
that help PBC? All right, okay, perfect. I'm glad one of us does. I knew you were here for a reason.
It's a very new drug.
So
it's actually
the
very,
question
very
is,
new. In Australia, it's only been around a few months, actually.
all right, okay. So can that help PBC and or liver enzymes?
So first of all, we don't know it's that new. And probably not.
Okay.
It'll help LDL cholesterol. I'm not an expert on Repatha, and it's very new, but it's an injectable agent to treat refractory hyperlipidemia, and in particular targets the bad cholesterol, what we consider the bad cholesterol for vascular disease, the LDL. And I can't imagine that's the most important thing. I can't imagine it would necessarily be useful for PBC, but we wouldn't really know at this stage. It's that new. It really hasn't been looked at.
Okay. Okay, perfect.
All these new
right,
questions today,
you.
Robert.
Okay. Yeah, it's good. It's good. I've never even heard of Repatha. But
Yeah,
now
it's very
new.
new.
So
It's
now
a
I know
very
what it
new
is, so
agent.
that's
Yeah.
helpful. So thank you for
Yep.
the question. Okay, perfect.
Oh.
So there's also, so again, I'm just kind of jumping on this bandwagon. So we've had questions in and around medications like Ozempic and those kind of things. Do we have any data in terms of have they been proven to be safe or contraindicated in and around PBC and that kind of thing?
I wouldn't look. We don't have specific data, and we don't have to most other diseases, but there are they're really so there wouldn't be good information, but there should be no reason that someone who has PBC that's well controlled, so not advanced liver disease again, you'd have to look at those people more carefully, but there should be no reason why they couldn't have Ozempic, and they're at the same risks as anyone else, Robert. Not they could have Ozempic or any of those other GLP-1 agents. I'm actually a bit of a fan because unfortunately people are carrying more weight these days, and so more people have fatty liver disease from their metabolic weight associated disturbances, and they've got PBC, and we know that the fatty liver is not good for the liver, and then so you've got two illnesses that are affecting the liver, and that it concerns us it really greatly concerns doctors like me. So if people can find a way to lose some weight, if they're carrying a lot of weight, that's only going to benefit their liver disease. And if they land up needing something like Ozempic for either their diabetes and for some people purely for their weight loss, I would think they should, and they want to try that, and there's no other medical contraindication. They could try that with regard to the underlying PBC. They're at the same risk of side effects as everyone else. Not everyone else. There's a significant bunch of people who can't tolerate these medications because of various side effects.
Gotcha. Okay. So we've got a message here in Click. It's definitely for you, not for me. It says, you are full of knowledge. I've not heard any of the specialists I have met know and explain this much. So there you go. Question is, are you able to educate the teams in our hospital? So here's a question for you. So that's a lovely message. So thank you for sharing
Yeah,
that
I
and sending
appreciate that. Thank you.
Martin.
Yes. That's very kind.
So my question for you is in and around teaching hospitals, hub and spoke models, all of those kind of things. So what can you tell me about kind of the level of expertise in Australia and the number of kind of bigger hospitals and liver units and that kind of thing?
I think,
I know we've
yeah,
talked
yeah. So
around this, but I don't have specific
yeah,
information.
I think the bigger hospitals, there are a lot of people who have expertise. So there's a lot of
Yep.
liver specialists, and some may have either as Robert knows, a particular interest in PBC more than most, and some people will have a decent interest because they're a liver specialist and they would have a decent interest, knowledge, and experience. And some people have a lot of knowledge and experience in and around Australia. They're people with a lot of knowledge and experience, and um, so and then there are a lot of doctors in general community private practice who either aren't liver specialists but gastroenterologists, and some may take the advantage of all these new drugs coming through and education around these drugs that usually are sponsored by the pharmaceutical company, but use doctors equivalent to myself to give lectures on the disease or interest on the disease. And um, it's incumbent on those individuals to come and educate themselves, because that's the bulk of specialists treating this disease. A bulk of specialists aren't sitting in a hospital clinic.
Yeah.
They are actually in their offices and seeing patients, and it's incumbent on them to keep up to date. My belief is if a doctor's just treating one or two or three patients in their practice, they should they really should be referring them to a specialist, someone with a special interest, at least for an opinion from time to time. That person may not feel it's that complicated to continue care, but that in that way that individual patient knows and that doctor knows they're still getting contemporary care. I'm going to add to this that because of all these new drugs coming through, doctors like to learn about new drugs, and there's much more interest in the broader gastroenterology community with regard to PBC and what we call cholestatic liver diseases because of these new drugs. So they feel they need to know about the drug, and so doctors don't want to make a mistake with safety, or they want to know the sequence of drugs. So there's definitely more interest, and there's even more interest within the liver specialist community. And Robert can attest to this because he comes to some of our liver conferences. If you go to PBC 4 years ago and if you go to like the American or European liver meeting, there's a little bit on PBC all the time and autoimmune liver disease. The last 18 months, there's disproportionately more on PBC, and it's really, the interest is huge, and the quality of those presentations is much better. Not that they were bad in the past, but to have a broader range of presentations to keep them of a decent standard is not that easy. But the quality is really generally, and I'm someone who knows a lot, so I still go to these to learn, and sometimes there's not a lot of new things to learn, but you can still see the quality of presentations and the approach to patient care is definitely changing in the liver community, and it'll leak out over the next several years, to a broader range of doctors. But there's still a big deficit in diagnosis and general practice, and there's a big deficit in providing contemporary care and understanding the disease and the way it should be understood in 2025 amongst the general gastroenterology specialists. And it's really their job to come and get educated and read the literature and attend meetings and keep up to date. And the people affiliated with our hospital tend to, and maybe that's because I have an interest, so they come and learn. But we did a meeting. Normally, drug companies or various educational bodies sponsor these meetings, and they hand over the education content to a group of specialists. And we did a meeting late last year, and the company concerned felt that they'd be lucky to get 20 specialists in Sydney, and 10 of them would be very expert on it, so they probably wouldn't learn much, and the other 10 would come and get updated. And they just, within 1 week of seeing out invites, they were oversubscribed. They couldn't believe the interest. And I believe it's related to the fact that there are new drugs on the horizon, and some doctors feel I better just make sure I'm not missing out. And that's not a bad thing if that's what drives them. I better not miss out on that information. And it was very well attended, very well received, and that particular company will run further meetings only because of that. They don't want to run meetings and 10 people come or 15 doctors come, and there's it's a lot of effort to arrange these educational sessions. Within our hospital, we the folks generally keep up to date, and then we'll end up getting the complex patients who should at least discuss with us, or even sent into the clinic if they're issues that one of my colleagues in more general gastroenterology practice is ambivalent about or uncertain about. I'm not sure that happens everywhere, though. I'll be honest, it doesn't happen everywhere. And in rural areas, it's very so. Obviously, there are less patients with PBC in smaller centres, but they by and large get very poor care, actually.
Okay, noted. Thank you. Yeah, it's easy to get to one of these big congresses. We were at the American Association of Study of Liver Disease, and their meeting called the Liver Meeting, and literally thousands and thousands of people there, and it'd be really easy to forget that PBC is a rare disease because there was so much action and information.
But they're speaking to experts, or at least a liver expert who hasn't really done much, but now they're moving into the PBC sphere because whatever they were doing before is a bit gone by the wayside, But there's definitely a strong interest. You'd have to say that, Robert.
Absolutely. Okay, I've got another couple of questions for you. Question number 1: what are the possible secondary side effects? It's moved. What are the possible secondary effects of fenofibrates?
Yeah, fenofibrates have a side effect profile that it can even cause liver toxicity. Very, not frequently, obviously, but it can cause liver toxicity. It can cause kidney damage and kidney failure. So that's the one I'd worry about most, to be honest.
Yeah. It's going to be interesting to watch the new medications and see what they do to kidney over the long term. So we'll keep an eye on that as well. Yeah, absolutely. Correct. Okay. Next question for you. Can you take immunotherapy for autoimmune diseases when you have PBC? So, for example, RA, lupus, connective tissue disease, are there any medications that are dangerous for the liver?
Really, there's so many immunotherapies and biologic agents out now, so I'm not going to know every single one of them, but we use a lot of them in gastroenterology practice, and they're perfectly fine. In fact, some of them might actually be good for autoimmune disease in the liver. There's no studies on it, but in theory, they could actually be beneficial, some of them. But by and large, immunotherapy should not be bad for your liver and should not interact with the medications prescribed for PBC. I've lost your
Perfect.
hair. I
Thank you.
can't hear. Yeah, for 1 second. But these are the questions you've got to ask your liver specialist, because you've got your illness that I don't know
Yeah.
about and I don't need to know about. But I'm talking in broad terms. I would be, advising people that it shouldn't be an issue and you shouldn't worry about that too much in broad terms.
Okay, perfect. Thank you. And I guess it's really, really important to look at people as whole people. Not just liver
Correct.
counts or not just and I think that there's been a number of your answers that have alluded to where you are in your PBC journey is more important than just having PBC in itself.
Yeah.
So I think that's a really important message. So thank you.
And generally,
Okay.
people, you'd need to prioritize your illnesses as well. Some illnesses. So I don't know your individual circumstances, but there's a priority to what's more serious at any one time, and your doctor should not say, "Well, I'm just treating this illness." Of course, a liver specialist is just treating your PBC, but we have to take cognizance of whatever else is going on with you and what your, communication with your other specialists, whatever your other needs are. So, usually you can work it out with your other treating specialists. Okay, we're going to come to a conclusion this would be a reasonable thing to do and should be safe, and we often have those discussions. To be quite honest, it's not uncommon for people to have multiple coexisting illnesses these days.
Indeed. All right, perfect. That's helpful. Right. My instinct tells me this is going to be a new one for you. You ready? Strap
Yes.
in. Hyperbolic oxygen chambers, are they good for
Yes.
autoimmune diseases and PBC?
Yes. Probably not, to be honest, but there's no
Okay.
study to show. There's zero studies on that. But I can't imagine why it's hyperbaric chamber, why the hyperbaric chamber would be helpful for autoimmune diseases in general. They really help they're useful to my knowledge, obviously they develop for the bends. That's what they develop for. So divers who get oxygen trapped in veins, that's what they need to release that very slowly. So they put them urgently into a hyperbaric chamber. But it's now used for a broader range of medical illnesses, particularly those which have poor blood supply and poor healing. And these PBC is not the case, and most autoimmune diseases are not vascular diseases per se. So I don't think they would benefit from hyperbaric chamber, but there's not been a study. But I can't see a rationale for a study, so I don't think that would happen. I haven't been asked that before, definitely.
Yeah, so I'm thinking live here, and that doesn't happen often. So we're in dangerous territory now. What are our thoughts in and around hyperbaric chambers and fatigue?
I appreciate that question. Again, I don't think there's data on that. And it would be
Yeah,
hard
yeah,
to do
yeah.
a study because most places have very limited access to hyperbaric
Mhm.
chambers. So
Yeah,
the
yeah.
people who it's divers, like say in Sydney,
Mm.
there's two hyperbaric chambers. There's one that government run one, and the priority is for people with the bends. That's what it's developed for. And then
Yeah.
everyone else is a secondary priority and has to be assessed. And I don't think they're going to be filling hyperbaric chambers with people with fatigue, because the people who desperately need it, where it's well validated for those diseases, are going to get access to that. But again, I don't think hyperbaric. I can't see how it would help fatigue, and in theory, you're looking at and until we understand the full mechanisms of fatigue, we're not sure what we're targeting really.
Yeah, yeah.
We know
Yeah, I'm
some
with
of
you.
the
Okay.
endpoints, but we don't know the beginning points.
Okay, perfect. Right, so we've got another question. I'm going to ask you the question. It's a little bit specific, so we'll talk in general terms. But if you have asked this question, again, I would encourage you to get in touch with us and we can talk that through with you in more detail. But the question is, so it says, I'm an URSO responder and also responding to the use of 40 milligrams of fenofibrate. So I'm assuming that this is a patient in the US. I've only consulted with one hepatologist. Do I need a second opinion?
To be honest, if you're doing very well, you don't need to have a second opinion. If you're responding very well, fibrates like bezafibrate and fenofibrate, and there are different ones in South America, etc. There are different ones used in different continents, depending on what's available. They're very useful adjunct drugs or second line drugs to people on URSA. So they're not wouldn't be effective drugs on their own. And if your
Yeah.
liver tests do well with the dish, if you didn't have a full response to URSO and they add fenofibrate in this case, or whichever fibrate, and you respond well and tolerate the drug, then it's quite simple. In general terms, and I don't know your specifics. If you're responding very well, you probably don't need to see anyone else, and you'll carry on and have a good response. In the future, and again, I'm not sure where you are, there are these newer drugs coming online which mechanistically are similar to fibrate type drugs, but are more specific for PBC. My bet is in more affluent countries they'll replace fibrate, but where economies restrict access to drugs, these are cheaper drugs, fibrate agents, and they're all used off label because no fibrate's ever been labeled for PBC. It's labeled for hyperlipidemia, but they're definitely useful drugs to treat people, and they're very useful in people with an itch as well, particularly.
Perfect. Okay, that's helpful. And so, yeah, so the phenofibrate question did come from the USA. What I would say also is I would add that there is, to use the technical PBC term, a metric ton of papers and publication and data from Japan who've been using phenofibrate for years and years and years and years. So there's some really good stuff out there. We have time for one last question, if I may, and it's in and around UTIs. So since being diagnosed with PBC, I have gotten a urosepsis and also chronic UTIs often. Are UTIs common with PBC?
Then they're actually not. They're not. There's no strong relationship with UTIs and PBC. So again, as I mentioned before, people with PBC can get other illnesses like anyone else can, and I don't think we can blame the PBC for that.
Okay, perfect. That's helpful. So this is interesting because I know when patients talk that this does come up. So which is fascinating. Now, help me out here, Martin. You may or may not know this, but so it was Andreas Kramer from Switzerland.
Yeah.
Now he talked about a synthetic sugar that your body doesn't react with or take in, which then interacts with the urea, which then helps stop UTIs coming out. Do you know what I'm talking about? Because I certainly don't.
I don't. No.
Okay, that's fair enough then.
So
Right, I will go back and have a look.
I'm going to take a pass on that one.
That's perfect. Okay, that's fine. And I will go and look into that, and I will mention that the next time we're on our Q&A. Right, Martin, I wouldn't get up at 2 o'clock in the morning for many gentlemen, but it's been a pleasure talking to you today.
Okay.
So don't take it personally if I head off to bed now, but thank you so much
for
today.
Have a good sleep. Good
right,
morning
you.
and good night to everyone.
All right, thank you so much. Great questions, by the way. I love the fact that we covered
3 questions I've never been asked before. That's a record.
Wonderful. Brilliant. All right. Thank you, sir. All the best. Take care, guys. Bye now.